All right, let's talk about that moment. You're a pathology trainee and you get your first really complex head and neck cancer case. To sign that out with confidence, you have got to know the CAP protocol for cutaneous squamous cell carcinoma inside and out. So today we're going to break down every single critical data point you need from the minute it hits the grossing bench all the way to that final sign out.
So, who sets the rules for all this? That would be the College of American Pathologists, or CAP. You have to think of their protocols as the official playbook for modern cancer reporting. These aren't just, gentle suggestions, they're the standard. They make sure every single report is comprehensive, consistent, and actually useful to the clinicians, no matter where in the world it's being signed out. So that's what we're going to do here. We're going to take this protocol and break it down piece by piece. What's the goal? Simple. To give you a rock-solid framework so you can walk up to these tough cases feeling confident and precise.
We're basically going to follow the entire journey of a specimen. We'll kick things off with when you should even be using this protocol. Then we'll dive into the primary tumor itself. From there, it's under the microscope to look at histology, grade, and invasion. Then we'll tackle margins and nodes. And finally, put it all together for the final stage. We'll even look at the two big staging systems, AJCC and BWH, and see how they stack up.
Okay, first things first. When do you actually pull this specific protocol off the shelf? Getting this right is so important, and not just for passing inspections. It's about making sure the patient gets put on the correct treatment path right from the start.
So this protocol isn't for every case. It's really reserved for the high-risk, more advanced ones. You absolutely have to use it for resections of PT3 and PT4 tumors, and for any case where you find positive lymph nodes. But just as important is knowing when not to use it. You don't need it for a simple punch biopsy, or for those early node-negative tumors. And you don't use it if the surgeon re-excised a site and there's no cancer left. Knowing that difference is your first big decision point.
All right, let's head over to the grossing bench. This is where the investigation really begins. You've got the primary tumor right there in your hands. And the data we collect right here, right now, is the foundation for everything else that's going to follow.
So right off the bat, you're asking four basic but crucial questions. Is it just one tumor, or are there several? Where exactly is it? Is it on the right, the left, or in the middle? And of course, how big is it? That one measurement, the greatest dimension in centimeters, is our very first clue for figuring out the T category.
Okay, we've grossed it in. Now for the fun part. We're heading to the microscope. This is where we uncover those really critical prognostic factors that are going to tell us how this tumor is likely to behave and what kind of treatment the patient is going to need. When it comes to grading, the protocol talks about two main systems. The first is qualitative. You're looking at features like keratinization and how ugly the cells are. The other, the Broder's system, is quantitative. You're literally estimating the percentage of the tumor that's undifferentiated. At the end of the day, they're both trying to do the same thing. Find those nasty, poorly differentiated, high-risk tumors that need to be treated more aggressively.
Next up is one of the most important measurements we make, depth of invasion, or DOI. And listen, the protocol is incredibly specific about this. You have to measure from the granular layer of the adjacent normal epidermis all the way down to the deepest part of the tumor. This is exactly why getting good sections at the grossing bench is so important. A tiny mistake here can literally change the entire T-stage.
As you're scanning the slide, you need to be on the hunt for perineural invasion, or PNI. This is a huge red flag, a major high-risk feature. When you see tumor cells wrapping or inside a nerve, it tells you this tumor has a more aggressive personality, and it's found a potential highway to spread.
But here's a key detail you can't miss. For staging, not all PNI is created equal. To kick a tumor up to a PT3, the nerve involved has to be pretty big, at least 0.1 millimeters, or it has to be deep to the dermis. That deep location is a really handy surrogate for size. It means you can make this critical call even if you don't have your micrometer handy.
So we've got a really good handle on the primary tumor now, but we need to know how far it's spread. So our focus shifts to the edges of the resection, the surgical margins, and then to the regional lymph nodes.
And the protocol itself couldn't be more direct about this. The explanatory notes flat out say that margin status is a key predictor of a bad outcome. Your call on whether that ink is touched by tumor directly impacts whether or not the patient might need radiation. So yeah, your assessment of that inked edge has some pretty major consequences.
A big lymph node dissection can look pretty overwhelming, right? But the protocol breaks it down into this really simple, logical workflow. Step 1. Find and count every single node. Step 2. Figure out which ones are positive. Step 3, measure the biggest chunk of tumor. And finally, step 4, and this is crucial, you have to actively look for extranodal extension. Extranodal extension, or ENE. That's when the tumor has broken out of the lymph node capsule and started invading the fat around it. Finding ENE is a game changer. It's an incredibly powerful sign of a poor prognosis. It automatically kicks the N category up a notch and tells the clinicians this is a much more dangerous situation. You absolutely have to look for it.
Okay, deep breath. We've gathered all our data, all the clues from the gross bench, all the findings from the microscope. Now it's time for the climax. We get to synthesize all these puzzle pieces and build the final pathologic T category using the AJCC 8th edition.
Let's zoom in on PT3, because it's a super common and critical staging decision. A tumor gets slapped with a PT3 label if it checks any of these boxes. Is it bigger than 4 centimeters? Is there some minor bone erosion? Do we have that high-risk PNI we just talked about? Or does it meet the criteria for deep invasion?
So, what in the world is deep invasion? Well, the protocol gives us a really specific two-part definition. It's either the tumor has invaded past the subcutaneous fat into things like muscle or fascia, or the depth of invasion, that DOI measurement, is more than 6 millimeters. So both the anatomic location and a hard number can get you there, which is why you have to evaluate both.
And finally, just when you think you're done, the CAP protocol includes an important alternative staging system from Brigham and Women's Hospital. Let's quickly compare them, because how they weigh risk factors differently really shows you how our understanding of this cancer is still evolving. This is so interesting. You can see how the two systems are looking at the exact same features, but using them in different ways. BWH just counts up 4 high-risk factors. If you have 0, you're a T1. If you have 1, you're T2A. 2 or 3, now you're T2B. It's a totally different way of stratifying risk, and it's powerful. Studies have shown that those BWH T2B and T3 tumors have a really high risk of going to the lymph nodes.
So you might be wondering, why bother including it? Well, it's because there's good evidence that the BWH system might actually be better, more specific, at picking out which patients are really at risk for their cancer spreading or even dying from it. So it's optional, but it's an incredibly valuable tool that gives us extra prognostic info.
And that really brings us to the final thought here. Staging systems aren't carved in stone. They're constantly changing and being refined as we learn more. The fact that the BWH system is even in the protocol is proof of that. So for us as pathologists, the key isn't just to blindly follow the rules, but to understand the why behind them, because the detailed, careful observations we make today are what will build the smarter, more predictive staging systems of tomorrow.